So my name is Jo Szram. I'm a consultant respiratory physician. I'm not an occupational health physician, and I work at the Royal Brompton Hospital, which is part of Guy's and St Thomas's Trust in London. And I also work academically at Imperial College London. And we have a departmental website that straddles those two research and clinical groups called Lungs at Work. So if you go to Lungs at Work, the website, it has lots of information about our team and what we do, our clinical service, our lab, our research interest. And there's a page for patients on there, and there's a page for referrers as well. And just to quickly update you about how our service works, because you might want to send me people. So we're an NHS service. We're free to providers. As long as your patient has got a GP or registers with a GP by the time we see them, it's no cost to business. They're seen as part of the NHS service. And we do that for England and Wales. We have to make slightly different arrangements for Scotland and Northern Ireland, but we are able to facilitate that as well. We see everybody within 6 weeks of referral. We're currently on a 2-week wait. So you can get seen and sorted by us quicker than most services, apart from fast track cancer in the NHS at the moment. And we work really hard to make sure we can give you and your clients really prompt advice about any respiratory issues related to their workplace. So enough about me. I'm going to talk to you about occupational asthma now. And just to outline the kind of things I'm going to be talking about, I'm going to use quite a lot of case presentations to talk to you about how occupational asthma might differ from what we call work exacerbated asthma. I'm going to talk to you about some of the common causes we see in the UK, things that might be a risk factor, how to recognise it, how to diagnose it, how to manage it, and what happens if you get a diagnosis of occupational asthma. What can you do in terms of outcome? So lots of people in the UK have got asthma. That is on their GP record. They're on an inhaler or they've had an inhaler, which is how they code things on their data. If you look at big studies of populations, you can see that about 1 in 10 people with asthma as an adult will say that their work contributes to their asthma. But that isn't all occupational asthma. That includes lots of different people. So the way we talk about attribution is to do with the relationship with work and asthma. So is your asthma related to your work or not? And that's broadly 2 categories. One is occupational asthma. So it's caused by exposures at work. And that might be IgE mediated. So an allergy or sensitization, or it could be an irritant induced exposure, normally a single high dose or several high dose irritant exposures. What once was called RADS, or equally a lot of asthma that is related to work is due to the work itself making the existing asthma worse. It's a little bit more complicated than that, of course, because some people have asthma since childhood, so you don't know if it's a new asthma or not. Some people's asthma goes away. It's quite common to hear from people who say, I had asthma when I was little, I didn't have it, and now I've got it again. And you don't know if that's a asthma that's new because of their work exposure, or whether that is an asthma that has come back, because about a third of childhood asthma will come back during adulthood. And you can't really tell the difference when you first start talking to someone. The difference in terms of definition is outlined at the bottom. So occupational asthma is induced by inhalation of the agent in the workplace. So it starts the asthma. In other words, if you hadn't ever worked with that agent, you will never get asthma, as opposed to work exacerbated asthma, which is a pre-existing disease and it's made worse by the work exposure. There's lots of terminological things that you can think about. I've put some pictures here for you to think about. So lots of asthma is there and there's nothing to do with work. So Jackie Joyner-Kersee won lots of medals and had asthma, and she was still able to be an Olympic athlete. So it doesn't preclude you from any job pretty much. You still can't get in as a fighter pilot with asthma, but once you are a fighter pilot and you develop asthma, you can still be a pilot. So there's some quite interesting sort of thoughts about how does that exactly work. You might think that if you've got really bad asthma, you might not become a baker or work with lab animals, but that isn't the case either. So the studies from Germany, where they do lots of work around apprenticeships, it doesn't matter how dusty the job is and how bad your asthma is, you might still go and do one of those dusty jobs, even if it makes your asthma worse. So big category in the middle of asthma exacerbated to work is important. That's a picture of a chiller in a supermarket. And if you go in and out of a cold room all day, especially on a hot day, you're going to get changes in temperature that really affect your asthma, and that will make it worse. And we normally talk about that as an irritant exposure. So it's not an allergy, it's an irritant exposure. And it's pretty common. And then finally, occupational asthma, much less common, what we call sporadic. In other words, it happens sometimes, not to everyone in the same working environment. So there are some people more vulnerable than others for various reasons. And that's a new asthma, and it's induced by something at work. So there you've got a picture of someone soldering, and that is a plume of solder, which is from colophony. And colophony is a respiratory sensitizer. So that is a known cause of occupational asthma. And you all know this far better than me, but in this case, while he's wearing a mask, which is great RPE, that is the bottom of the hierarchy of control. And actually, he should have good extraction, or even you could have colophony-free solder to prevent or reduce the chance of developing the disease in the first place. So as you can see, 95% of that is sensitization, about 5% would be due to a high dose irritant. How much occupational asthma is there? This is a really old study, but it's an interesting one. So this was some medical students that some years ago, they're both consultants now, went into a GP's surgery and looked at all the records of that GP and worked out who had asthma, and then looked through the records of the people with asthma to see if it was adult onset, and then looked to see how many of those had their occupation recorded, of which most did, and many of them had a high risk occupation, but only in minority of them, someone had gone, I wonder if it's occupational asthma. So when you look at primary care services, they are not equipped to tell you whether your client has got occupational asthma. And one of the things we will always say to you is, please, if that is your question, refer to us directly. Do not write to the GP and ask them to refer, because all you're doing is delaying unnecessarily for the patient. We always write back to the GP with our answer. They don't mind. It saves them a job, and they get the same information as they would do if they wrote us the letter. It's just a waste of time in the journey. We will accept the referral from you directly, and that includes doctors, nurses, advisors, anyone who's a healthcare professional working in your service. We're more than happy. We don't accept patient referrals for occupational asthma, but otherwise, all good. You can also see, therefore, that you're missing a great deal of the occupational asthma that might be there by just not asking the question in primary care. The comment made in that paper is, because it's a really diverse group of people in the practice and lots of different jobs, it's quite hard to remember which jobs might be a problem. You in occupational health have an advantage, because the reason you're there looking for occupational asthma is because there must be some form of residual risk, and therefore you're thinking about it as a possibility. So asking GPs to do that is pretty hard. So how do we think about occupational asthma? So as I said, it's an asthma that came along because of the job that they do. And the diagram is there to represent the fact that someone's asthma might go away and then might come back again when they get into a new job. There's another way of dividing up occupational asthma, and that's into high and low molecular mass agents that cause the asthma. And I'm going to talk about those in a bit more detail and why it's important which one it is. It's really not uncommon in certain settings, and there's a list of these in the BTS asthma guidance, occupational asthma guidance and good practice document. So obviously bakery and so on. It's often really difficult to manage, so it's important to identify it. You can give people with occupational asthma more and more inhaler and other medical treatment, but it will just get worse. And therefore, the easiest way to solve the issue of the asthma is for them to be removed from exposure. It has the best prognosis, but obviously that results in significant impact on the patient themselves and employment disruption. And whilst they are eligible then for state benefit and to claim compensation, that would never recompense them for the loss of their earnings that they would have had if they hadn't got asthma in the job. So prevention is a really important aspect of what we should be doing, but can be really hard to implement. Occupational asthma is the most common short latency occupational lung disease in the UK. So short latency is that you get the asthma in the job that you're working in. You don't find out about your disease 20 years after you've left. So as would be the case with asbestos exposure or silicosis, these happen really quickly within a few years. It's defined also with an appropriate history of exposure to an agent that can cause occupational asthma. So you can't just say occupational asthma to something, because that's not going to give you the information you need. And it has quite a typical symptomatology, which I'll just go through with you. So the first aspect of those symptoms is a period of latency. So you do not get occupational asthma on your first day at work. You will get it within a few months, sometimes a few years of starting. There's also sort of a march of symptoms. So you will normally start with eye and nose symptoms first. So people often report they've got a cold all the time, or they've always got hay fever and it never seems to go away, even in December. And also they will often flag on your sickness absence work as having repetitive chest infections. There is the ability to test them with specific immunology to look for allergy or sensitization. And also we use a lot of serial peak flow measurement in the diagnosis of occupational asthma. Here's a picture of a baker in a supermarket bakery. It doesn't look very dusty. You can see there's a table with some flour dust on it though. So probably he gets peaks and troughs of exposure, which are just as likely to sensitize him as being exposed to flour dust all day long. Knowing what's the situation that someone is working in is really important. And then once you've worked out what they do and where they do it, you can start picking into the natural history of their symptoms and what's been happening to them. So say this guy's called John and he's in his mid-20s and he will have started working in a bakery at the age of 18. He might have developed his nasal symptoms within a couple of years, and then a year after that he'll start finding that he's wheezy when he's playing football, not keeping up with his team. And then sometimes people don't notice that their symptoms are work-related until a bit later. So he noticed he went on holiday and he got completely better. This gives you this latency period. So it took him 2 years to get the nose symptoms, 3 years to get some chest symptoms. And as you can see, the risk of a disease occurring, occupational asthma occurring, is highest within the first couple of years and then drops off, goes down, doesn't ever quite reach zero, because there is always a signal of people where their exposures change or the intensities change and they sort of have enough exposure to get sensitized later on. But that's the general rule. Sensitization is measured with specific IgE, so you can do that with a blood test or with SPT, which is a skin prick test, which we do in our clinic. You have to get these bespoke. They're not a kind of standard allergy clinic immunology test, which is why we have our own lab. There are some off-the-peg blood tests that you can use. So it is possible to do a blood test to alpha amylase through a doctor's lab or wherever, but we obviously do our own within our laboratory, and we look for concordance. So your skin prick test and your IgE normally match, which gives you a really consistent result and is very helpful. And that's a 99.9% certainty if it's positive that they're sensitized, and if it's negative that they're not. So we're very confident in our immunology. You still have to put it together with all the other tests. So what you're seeing here is a bunch of work-related symptoms with progression and then evidence of sensitization. Here you can see the list of the most common whole allergens. So these are high molecular mass allergens that can cause occupational asthma. So these are all respiratory sensitizers. So you can see in baking, you've got flour and alpha amylase. It's a common improver used in commercial bread production, and also egg, which can be aerosolized depending on how you're mixing. We see a lot of people work with animals, particularly in medical research where they're working with mice and mouse models, and then also a variety of other animals from vets and zoos and things, insects, and also occasionally latex, because powdered latex gloves, whilst they are no longer around in the NHS and most healthcare organisations, you can still buy them on the internet. So you do see people who will buy a box of gloves because they're cheap and then find their whole workforce gets sensitized because they're all using powdered latex gloves. Food processing is another common cause of referral for various reasons. These are all, remember, proteins we're looking at. So food generally that does have protein in it, and if it's aerosolized can cause occupational asthma. People that work in the detergent manufacturing industry, so washing powders, dishwasher tablets, and so on, will be exposed to a variety of enzymes that dissolve our food to clean our dishes and our clothes. And then finally, again, latex, as I mentioned before. To contrast these, here are the most common low molecular mass allergens. So here you've got what we call hapten protein conjugates. In other words, there's a chemical which is a hapten, and it's reactive. So it might be a reactive salt or reactive dye or something like that. So it's chemically reactive, and it basically meets and then binds in, conjugates with one of our innate proteins and becomes essentially foreign to our own body. So it looks like an allergen, and your body starts generating an IgE response to it. And these are the most common causes of low molecular mass occupational asthma reported in the UK. As you can see, isocyanates figure quite heavily, both in spray painting and making the foam. So that's the kind of foam that you have in your seats that you're probably, some of you are sitting on, like your office chairs and so on. But it's used in lots of industries, very diverse group. You've got people working in electronics, like the solder I showed you earlier, as well as things like cyanoacrylate, which is used in glues and various adhesives, and persulfate salts, which are used to clean things chemically. You can then see further down woodworkers. So if it's a tropical wood dust, it creates an acid, which is the hapten in that situation and can cause sensitization. So it's not oak and pine, it's a sort of tropical hardwoods from various rainforests and things. Hairdressers who are exposed to persulfate salts in the dye for people's hair, dentists and people that work in orthodontics and orthopedics who are again exposed to two-part glues and foams and things, people who work with dyes, and finally precious metal refining. This isn't platinum for jewelry, this is platinum salts, which are used in catalytic converters and other chemical processes, so they're reactive and very potent allergens. So you've got two groups of allergens, and the difference, apart from the mechanism, as I explained, is in terms of their history. The whole allergen sensitizers will all cause iron nose symptoms and induce a specific IgE response that we can measure. And in that workplace, people who are atopic are much more likely to get occupational asthma, whereas in the low molecular mass group, it's about 50-50 whether you get nasal symptoms or not, and only some we can measure IgE responses in. You also can't, there's no chemical or low molecular mass allergen in which you can compare a skin prick test and an IgE. They either have one or other. So platinum salts, we have skin prick tests, and the isocyanates, we have an IgE test, and it's nowhere near 99% sensitive. It's about 30% sensitive. So most people that we end up challenging and diagnosing with isocyanate asthma won't have a IgE that we can measure in their blood. And that's probably because the way that the chemical reacts with the protein is a bit different in every person, and therefore it's hard to make one antibody that's always going to pick up the disease. Peak flows are really useful, and here you can see a plot from somebody who's done, as it says in the box on the right, every 2 to 3 hours has done a peak flow, best of 3, written it down on a diary for us, and then we've plotted it. They've done that for us for 4 weeks, and they've done it both at work and also on days off, from when they wake up to when they go to bed. So you end up with 6-7 measurements every day. And then we plot it like this. I'm just going to use the little laser pointer thing to go through the picture. So you've got on the bottom days, you've got 27 days. On the y-axis here, you've got peak flow. And you can see this red line across the middle is a predicted mean based on this person's age, gender, and height. Then you've got 3 lines of data. You've got the best result of the day, the worst result of the day, and the mean of all the readings of that day. So you can see these 3 lines going across the trace. The blue columns are work days. So that's day 1 to 3. And then he's got 4 days off, day 4 to 7, and then work off across this recording period, which gives us an idea of work variability. You've also got at the top numerically a percentage variability for the day. So on the first day, you can see the difference between the bottom line and the top line is quite big, and that's a 23% variability, which is significant. Everything over 15 is significant. Having said that about day 1, what's common in people who've never done peak flows before is that they're not very good at them. It takes them a little while. So you often start off like this, and we would call this increase on day 1 to 3 a learning effect. So he's got quite good at it by the time he gets to day 3. And you can see day 4 to 7, his peak flow is quite stable. He gets really good results. And now you can really see this difference that when he's off work, his peak flow is better and isn't variable. He's got sort of single figure or low teens figures of variability in the boxes at the top. The lines are closer together, and then he goes to work, and these lines spread out, become more variable, and the numbers in the top get bigger. So he's got work-related variability because he's much more variable here than he is here. So he's effectively only got asthma at work on this test. So that's a very good work-related variability example. Oh, and peak flows are about 75% sensitive and nearly 80% specific for occupational asthma. They will be abnormal in other conditions, but it's a very good test to help us rule out other conditions and also rule in occupational asthma as the likely cause of the problems. This is the same data, but only taking the morning and afternoon plots and plotting it every day. And you can see here, you can't see anything compared to what you've just seen on the other graph. If you put in the work and home, you can see there's really no difference. You can't really see a work-related variability on this. It's not enough measurements. And that's why we ask people to do so many measurements in a day to get that really useful information. So just to summarise where we've got to so far, we've got an appropriate history of an exposure to an airborne sensitising agent with typical symptoms that are work-related, so worse at work, better away from work, the eye and nose symptoms and recurrent issues of infections and hay fever, some marker of immunology where possible, and a serial peak flow measurement. We have the facility to do specific provocation or challenge testing, but that can be quite laborious, and we do not do it in every case. In fact, very few cases these days, because we have other ways of being able to make the diagnosis. Once you've made the diagnosis, you will manage it as far as possible by avoidance of the agent. So sometimes that's possible through relocation or substitution of the agent. It's not possible to just put on more RPE because that will not completely avoid your exposure. It will only reduce it, which is great for prevention, but not so good for treatment once you're sensitized. And just a reminder that if you're employed and you've been told you've got occupational asthma, you're then eligible to claim industrial injuries disablement benefit, which is a state benefit. Take my pointer off now. There we go. So that's all quite easy. If it's not that easy, we do have to resort to challenge testing. We do this when we're not sure we can make the diagnosis without it, particularly if it's a new agent. For example, we sometimes get asked about people who are testing new drugs that haven't come to market yet. So they can be sensitizers, and we've had to do that before. Or if they're working with several agents and they need to know which one it is, because then they can work out where they should be working. We don't do it for people just because they ask us to, because they want to make a legal case. That's not an appropriate use of NHS resource. And there is very limited resource for challenge testing. There are only 3 centres in the UK, and we're the only one with a dedicated chamber just to do challenge tests. We call it a single blind test. So that means we know what agent the person's exposed to, they do not. And we put them in a chamber for up to half an hour per day, which is an exposure period, and then we measure their spirometry sequentially over that day to look for drops and so on after exposure. We also measure something called PC20, which is how you measure how sensitive someone is to histamine or methacholine, which causes everybody's airways to tighten. But for someone in the asthmatic range, that they need a lower provocative concentration, or PC20, to drop their lung function by 20%. And that's a recognised test that we use in all sorts of other measures, such as for athletes and so on, to diagnose asthma. Here's some examples of some challenge tests. This is someone doing a powder tipping challenge. So this is how we might test people from a bakery with powder. On the right, you can see one of our nurses spraying isocyanate into the room, which has a monitor in it to make sure the level is safe. And then we expose people for very short periods compared to their 8+ hour working day. The middle picture is a sanding challenge with some tropical hardwood, and then finally at the bottom, a glue mixing challenge with a 2-part glue containing methacrylate. So they're really not very high-tech exposures, but they give us what we need in terms of signal and exposure. This is the kind of data we get from a challenge test. So this is a baker's test, and he's been exposed to amylase in increasing concentrations. Again, just to use my pointer, you can, there we go. You can measure their FEV1 after a challenge. So they step out of the challenge chamber here and start doing their spirometry regularly every 5, 10, 15, up to an hour minutes, and then hourly thereafter until the next day. You can see they've had 4 different days of challenge. The first one, the control day, which is this red line here, you can see it doesn't move from the baseline. There's no asthmatic response. And then the same with a low concentration of amylase for a short period of time. then we 10 times increase the concentration. This is a protocol for this one because we've done so many of them. And you can see it's starting to drop here with a mild early response, but not yet significant. It has to go over 15% to be a true positive. And then we go up just a bit more, so just over double amylase for a shorter period of time. He came out early because he was symptomatic, and as you can see, he suddenly dropped his lung function by 50%, which then rapidly improved. And then he had a late response later in the day, in the evening. And this is quite a typical asthmatic response, which can be either an early only, a late only, or a dual, which is what this is. Early gets better and then late. And that fits with the pathology of asthma and how the inflammatory cascade triggers off when you're exposed to an allergen. We see this when we do studies of hay fever and other types of allergy as well. So it's quite a typical reaction. Here on the right, you can see that he's had various PC20s before and after each challenge day, and greater than 16 is a normal non-asthmatic response. And you can see that steadily over the week, as he's had his different days of exposure, his PC20 is reduced, such that after his big exposure, this one where he's had this big symptoms, the next morning he only needs a concentration of 4.8 milligrams of mil of histamine to trigger a drop in his spirometry by 20%, which is an asthmatic response. So it's a very tightly defined type of challenge test, and it's all subject to quite strict guidelines that have been written and approved across Europe to do these tests. Not everything is this straightforward or that easy to measure, so I'm just going to go through a few cases that have been referred to us just so you get a picture of some of the other kinds of condition presentations that we might see. So this was a 23-year-old man who was in the armed forces and working as an equipment fitter, and he was exposed to a variety of different chemicals, so it was quite hard to pin down a specific exposure. He also had a really strong past history of atopy in his childhood, and when he started, about 3 months after he started his training in the armed forces, he started developing symptoms again of wheeze, a cough at night, and chest tightness, and he was given asthma treatment and he got much better straight away. That September, he went on leave for some weeks and he found he was completely better, stopped all his treatment and had no symptoms, and had at that time a normal peak flow. So he was referred to us because they were worried he might have occupational asthma. They wanted to know how secure the diagnosis of asthma was and what they should do with him in future in terms of his work and any deployment, such as going abroad and going to particular areas in the forces. So we saw him in clinic in November. His symptoms coincided in June with the pollen season, and by the time that he went on leave, the pollen season had ended. So it seemed to be a seasonal as well as a leave-related issue. We found that he was sensitized to grass pollen, so it fits with his past history of hay fever. And in November in clinic, he had normal spirometry, so he can see his values are over 100% predicted. And importantly, we also test people for reversibility. So it's kind of the opposite to giving histamine and making your spirometry drop. We give them some salbutamol and see if it increases. And he only increased a tiny bit, which is not significant. So he didn't have asthma by the time I saw him in November. He then went away and did some more peak flows at work, because obviously the question wasn't, has he got asthma at all, was, does work cause him to have asthma? And remember, these were various exposures, but within a sort of common area workshop. And you can see here, compared to the one I've just shown you, this peak flow shows no real difference between his days off and his work days. And importantly, very little variability in terms of the difference between his best and worst peak flows. As you can see, they're all single figure numbers at the top. So this is not occupational asthma. And we also, when he came back to see us, had a histamine test just as a one-off, and that was completely normal. So away from June, in December, his histamine was normal. So I answered these questions in this way. I said, no, he doesn't have occupational asthma. There's no work effect. There's no evidence for one. If he does have asthma, he only has it sometimes, which is called seasonal asthma. And that is allowed. Not everyone has asthma every day all the time. And so therefore we were very relaxed about his future work and deployment, and felt that really he just needed to know that in the season he should think about having asthma inhalers and treating his hay fever as well to make sure that he was as well as possible. So although he's referred as a possible occupational asthma, it was not an occupational asthma. We do see a lot of bakers, so I'm going to talk to you about a different baker now. This guy again worked in a supermarket, and he was what's called a scratch baker, similar to the first guy. So that means he makes bread from scratch, i.e. mixes flour. And he'd been started his working life after school as an apprentice in a bakery for 2 years, and then he'd moved to a supermarket, but he wasn't working in the bakery for the first 8 years. He just worked on the shop floor, learning about the business and all aspects of working in the supermarket. They then found out he was a baker and said, "Can you come and be a baker?" And he said, "Sure," and started working the supermarket bakery at the back of the shop. He was again known to be atopic with cat allergy and hay fever, and he'd had asthma since he was 5. And his asthma had never gone away. He still had it, and he was using his inhaler every day, a never smoker. What he was telling us was that when he worked in the bakery at first, he'd never had work-related symptoms. But when he went to the bakery in the supermarket, he found he was much more breathless, became less fit, and he found that every time he went into the freezer, his chest would get tight, he'd get a sore nose, and that would make him sneeze. But he would generally get better on his second day at work. So it was always worse on day 1, and then it would improve. This is exactly opposite to occupational asthma, which just gets worse with increasing exposure. We also did his immunology, so we found he was atopic, but importantly, his immunology tests were negative, and so we could reassure him that he wasn't allergic or sensitized to bakery products, so he didn't have baker's asthma. He definitely had quite badly controlled asthma, as you can see from his peak flow. He's got very up and down peak flows overall. They are definitely better away from work here. You can see on days 13 to 15, but they're still very variable. He's up in double figures, solidly over 15% a lot of the time through this trace. So he's got asthma all the time. It's just exacerbated by his work. So he's got work exacerbated asthma. So we told him that, and we assured him and gave him better asthma treatment, a good asthma plan, and sent it back to you in Occupational Health to look at his exposures and see what they could do about that. And obviously, he's not eligible for benefit. So getting this distinction between occupational asthma and work exacerbated asthma is really important for the person and also for the business. So how do you do that? You need to look, as I said earlier, for latency, which work exacerbated asthma doesn't have. Any symptoms away from work is a bit more difficult, so you have to be quite careful about asking them about work relationship. Peak flows really help you with that. Looking at other symptoms such as eye and nose symptoms. It also is important for outcome. So we know that if you keep being exposed to something in occupational asthma, it will make you worse and worse, whereas work exacerbated asthma, as soon as you stop being exposed, your asthma will go back to how it would be anyway. It doesn't affect your long-term health or prognosis. Also, good treatment works really well for work exacerbated asthma and is really not very effective in occupational asthma. RPE, again, really good in work exacerbated asthma, will not help you for very long in occupational asthma. We do occasionally get people who are in fixed term contracts working, for example, doing a PhD with animals. They can do that for a few months up to a year, but any time over that, it becomes much more difficult to control their symptoms and their disease. So avoiding is good in occupational asthma. You don't need to do that in work exacerbated asthma. You can just manage it. And again, the legal and compensation implications are different for the two conditions. So sensitization sometimes is easy. A baker is a baker. That's quite easy. But there are lots of people who work in much more complicated jobs, and finding the sensitizer or even identifying one at all can be quite hard. So you've got 3 ways that can work. You know the thing, and it's a sensitizer. You know that they work with something that they tell you triggers their symptoms, but you know it's not a sensitizer, or you have no idea and you have to try and figure it out. So the rules of thumb being airborne proteins are sensitizers. Chemicals are not, in terms of things that smell a lot, don't tend to be sensitizers, weirdly, but they will tend to give people symptoms because they're irritant and quite volatile, and that's why you can smell them. It's really important that you don't tell someone they've got occupational asthma unless you're absolutely sure that they're exposed to respiratory sensitizer, and we're very careful about that in clinic. GPs will often write occupational asthma and just send you back a letter saying they have it, and then you're kind of stuck because you don't really know how they reach that diagnosis apart from just asking people, which is probably not quite sufficient when it's quite a life-changing diagnosis in lots of ways. So what do you do with an agent if you're not sure? If you know, that's brilliant, carry on. If you're not sure, you can obviously look at the data sheets. You can ask us for some advice. That's why we have our advice email. There is a short list of substances on the HSE website that you can consult, but it's not extensive. And we know of over 300 asthmagens, so there's way less than that on the list. Obviously, what you're looking on data sheet is for risk or hazard phrases. The correct ones for occupational asthma or respiratory sensitization are R34 in old money and H334 in new. And so if you find that, then you know you've got a sensitizer and you can kind of proceed with that too. If not, you've really got to be a lot more careful. Unfortunately, data sheets are not all that they're cracked up to be. So this is one for a contact lens solution. That is it's not the solution to clean them. It's the solution that you put as a premix into some wells and then you shine it high UV light on it and it hardens and becomes a contact lens. And this we referred a patient from here who turned out to have occupational asthma. And this data sheet, it's as this is the only compound they use in the whole factory, does not have R32 on it, 42 on it, and therefore on the face of it didn't look like this person was exposed to a sensitizer. Unfortunately, he is, and the data sheet's incorrect because he's exposed to a methacrylate, which is a known respiratory sensitizer, and we've challenged plenty of people with methacrylates, including him, that have an asthmatic reaction and is the cause of occupational asthma. So you have to be a bit careful about taking the data sheet at face value. So it's often worth asking us if you're not sure as well. You all do health surveillance for occupational asthma, so I thought I'd talk about that a little bit. This is a case we got referred from a hamburger bun bakery, also baker, and he'd been working there for 9 years, and they'd been doing a spirometry most years. Interestingly, the previous company before the person who referred him had just been doing the spirometry and putting it in a cupboard, so not massively useful as a surveillance tool if you just do that. And it was actually highlighted by the person who referred him in 2009, who got it all back out of the cupboard again and gone, actually, this is going down and up and all over the place. And they were quite worried because by then he'd developed some symptoms of wheeze, but actually going back, he'd had a runny nose for years, couldn't really remember when it started. But he wasn't sure it was work related. And there was quite a strong family, if not a personal history of atopy. We then saw him in clinic. We do our clinic on a Monday afternoon. They've normally had the day off to come and the weekend off before, so they pretty much always have normal spirometry. And this basically is like a reverse challenge test, isn't it? This is exposed, he's got lower spirometry, and now he's been unexposed for 3 days. All his asthma's gone, he's got normal lung function. We did ask him to do some peak flows for us. Again, these were quite variable, as you can see, although variably variable, so sometimes vary and sometimes not vary. So on balance, we thought, well, it's suggestive but not diagnostic. Having said that, if you look at his spirometry, he does have a big loss with up and down measurements, so a variable loss in spirometry, which asthma's variable, so that sort of makes sense. And importantly, he was sensitized to flour. So on, based on all of that information, we felt it was better for him to be relocated, which he was, and his peak flow charts improved. And he got much better. And actually, he never started asthma treatment at all. He just, he was already taking nasal spray and he just took that. And as soon as he was away from exposure, he got better, which is a really great outcome for him. And they were able to accommodate that for him at work, which is good news. Here's another case from health surveillance. So someone, again, a baker, had been working for ages, and but 2 years in the role where he was exposed in a new company, and he'd started to get symptoms. So clearly the other job where he'd been a baker had been better controlled in terms of exposure, and he'd managed to get quite unwell and ended up in A&E with chest tightness and exacerbation of asthma. This is his spirometry, which you can see is not the best quality. I think that's another point about spirometry and how difficult it can be. And here you can see he's got both a low FEV1 and FVC, but in his ratio does end up just about obstructive. So on balance, again, he was referred in on this, but as it quite rightly says on here, this is more of a restrictive pattern, which is not what you'd expect to see with asthma. And this is much more likely to be poor technique rather than a true representation of his lung function. So nevertheless, with the history, which was very suggestive, we persevered. And this is his peak flow test. So a diary of 23 days. again, a different sort of pattern. You see all sorts of appearances, but a lot of variability. And as you can see, if you look at the top at the numbers, he's much more variable at work than away from work. So again, much more likely to be occupational asthma than not. And importantly, in Baker's, as you all know, we've got immunology tests, and his flower was very high. 80 is an incredibly high level of IgE, strongly suggesting that he was very sensitized, and therefore that was the cause of his symptoms. And so he was relocated, and his spirometry, by the time he was moved into a restaurant, because he was actually a trained chef as well as baker, he moved to the restaurant in the company. And you can see here there's these peak flows, 1 week in the bakery, and then this is 3 weeks in the restaurant. And he basically, within 3 weeks, became completely non-asthmatic on no treatment. So it's really important to identify it, because it really does help people's health outcomes. There are other ways of doing surveillance. Immunology is used quite a lot in certain industries, and I've just presented these here in summary. I've talked about these exposures before, and these industries will use skin prick tests or IgE as a way of picking up sensitization rather than looking for lung function or sort of more direct respiratory ways of looking at it. So they'll literally just do people's skin prick tests or blood tests, and then worry about the ones who have got positive tests, and then ask them questions and do it that way around. And that might be to find them, it might be to work out if there's a problem in a specific area, or it might be just to make sure that you know when someone starts with you, like in the animal group, if they come with their allergy, you're not the one who's responsible for it, which is also probably quite important. This is how bakery supermarkets do this now, because they can't do spirometry on everybody. So what they do is ask people to fill a questionnaire in, and if they say I've got symptoms, you get a sort of longer questionnaire or perhaps a phone call with one of the clinical team. And if they say it's yes, they've definitely got some symptoms that are work related, they will get a blood test done for the bakery allergens, and only those people who are positive will then get referred to the hospital for a diagnosis, based on the fact that, as I said to you, there's a 99.9% concordance between the sensitization that you see in the blood and the disease. So it is a reasonable approach, and is much easier than trying to get around several hundred bakeries with 3,000 bakers every year, by which time, as soon as you finish, you've got to start again. The problem with these approaches is that, and any approach to surveillance actually, unless people tell you the truth, you're not necessarily going to find them. And this is a research project we did where we looked at this 3,000 odd bakers in the company, and we just did a survey of a smaller number of them. This was several hundred, and obviously because we did it face to face and went to the bakeries, we got a much better response rate, but also more of them were likely to tell us they had symptoms because we were literally sitting in front of them. And also, don't forget, it was anonymous, so we didn't tell the occupational health team who said they had symptoms. So you can see that compared to a 22% saying they've got symptoms to occupational health, we had 64% tell us that they had symptoms. So really, you're losing a lot of people at the beginning of the process who choose not to tell you about the symptoms because they know it might mean they lose their job. And that's always something to consider. So just to summarize, we make the diagnosis by taking a history to look for work-related symptoms and exposure to a sensitizer. And we talk about days away from work and holidays. Then we look at ways to work out if someone's sensitized and what they're sensitized to, and that varies depending on high molecular mass or low. We look at their workplace, and sometimes we visit workplaces as well. We also look at whether we think they've definitely got asthma, and we have lots of standard techniques to do that. That's a respiratory thing. But we also look at the relationship between their work exposure and their tests, and look for either serial peak flowchart results or a challenge test. And these are two ways that we can look for work-related asthma. So, all good so far. We've made a diagnosis. What do we do next? We tell them a variety of things which are evidence-based. So we know that if you continue being exposed, you'll carry on having symptoms. If you keep on going, your symptoms get worse. It's hard to use more treatment, and a mask isn't going to solve the problem. And there is a risk to their future health. We know if you stop working, you're more likely to improve, and it takes about 2 years. At that point, people generally plateau. And again, if you look at the group data, a third of people stay the same. A third of people get completely better, like the two I showed you, and a third of people do get a bit worse, but are still able to be controlled. The big impact really is socioeconomic, because often they lose their jobs and they often lose pay, and it's quite hard for people in their midlife sometimes to get a new job, particularly if they've got no ability to move location. And yes, they will get a benefit, and they could make a personal injury claim if they can show that someone's failed in their duty of care, but they invariably do not get a huge amount of money, even if they're successful. There was a cost estimation by a group in Birmingham some 15 years ago now that's calculated £125,000 per case as a cost in terms of being split up between the employer, which is very small, the person, huge, and the taxpayer, i.e. us, huge also. And in real money, that's about 264k per diagnosis of occupational asthma. So it's a costly disease. It's also important to remember that the patient can often feel quite in the centre of a storm, because not only are you worried about them, we're worried about them. They might even be going to other doctors as well. But also, if there's then an HSE inspection and review, that can cause quite a lot of friction. And then obviously the sector and the employer themselves can also be quite interested in the case for various reasons. So just to summarise, this is how we spot the case. This is literally everything I've already said to you. We've talked about some of the pitfalls, which is confusing the diagnosis. So try and be really specific about that. And if you're not sure, ask for help. Think about what the agent is. We're really keen that you don't move people out of work too quickly, because you can't do a work-related peak flow if they're not working in the place that they're getting the symptoms, which is why we see people quickly. And unless there's a significant risk to their health or life, we wouldn't ask you to move them. So if you need any advice about that, we're happy to talk to you, and try and use the standard in the guidelines to look after them as well as possible. And really, it's all in the history. Immunology helps you, and peak flow helps you. I've put the slides in from the clinical statement that colleagues of mine have written. We have a network across the UK, so the Brompton isn't the only centre. We have centres in Sheffield and Manchester and Birmingham, and a few small clinics in places like Newcastle and Belfast. But this statement has a whole detailed algorithm of what to do to make sure no one misses anything, and some flow charts and a kind of key which things should we always remember in our cases, which is quite helpful. We do measure through surveillance through a voluntary reporting scheme, which is run by the University of Manchester, called SWORD, which surveys for various diseases, and occupational asthma is a big chunk of that. There's also a reporting one for general practice as well, which gives us lots of data. So in summary, occupational asthma, work-related symptoms, that's the first thing, always ask people. Immunology can be really helpful, and we're happy to help you with that if you need. But really showing that someone's got asthma and it's related to their work exposure is the most important bit of what we do. And impact cannot be underestimated, because you can cure the asthma and certainly make it a lot better. They're much more likely to have a better outcome if you find them quickly and deal with it quickly. But in any case, it will always have some significant cost in terms of quality of life and economically. And that is unfortunately still mostly borne by the patient themselves. So thank you very much for listening. I'm going to stop sharing. I'm happy to take any questions, and I'm very pleased I've left myself 10 minutes. Silence. So apart from Charlotte having a problem with her connection, hello, Colette, save me from myself. Oh, I can't hear you for some reason. Maybe it's just me.
Apologies, I've got to put my microphone on.
Amazing. I was like, because it's normally me.
Yeah, we've just had a recent case of a member of staff who works in our biological sciences unit. She's a technical member of staff. And she had an exposure to something one day. She has got existing asthma, not work related, but just asthma. And there was something that had an odour in it, so it was a biological agent with potentially a chemical. We still don't know what it was. and it's exacerbated her symptoms, and she's had to up all her medication, and she's now on some COPD medication for about a month or something to try and see if that helps. But she's continuing to have peak flow readings that are worse than what she normally would, and it doesn't feel as though it's controlled. Would that be typical? Or would that be based on what you're saying? It sounds as though that wouldn't be.
I think that's someone that I would want to see, because that doesn't fit a pattern very well. I think anyone you can't get on top of, we would review firsthand. I mean, it's obviously really difficult because we're literally having a 2-minute conversation, but
yeah,
you know, I know it doesn't fit the picture. So you'd need to look at that a bit more, I think.
Okay. So it doesn't fit the picture of a work exacerbated. Right.
Well, it does, but maybe there's something that's being missed there in terms of what is it at work, and can you reduce that? Because you don't really want someone who's still getting unwell at work all the time.
Yeah. So it sounds as though potentially she might be getting exposed to something.
Don't know. I mean, it's just, but based on what you said, I'd want to know. I'd have a lot of questions for that person about what's going on there. So that's helpful. More than happy if you want to email me and we can talk about it in a bit more detail. I'm more than happy to do that.
Yeah, that would be great. Yeah, thanks very much for that.
No problem.
Thank you.
That's all right. Oh, thanks for all my thanks. Chris.
Yeah, just a general question. With regards to isocyanates, you've stated that the IgE testing, it's not very reliable. I think you stated a figure of around 30%. If the workplace monitoring regime involves regular urinary analysis and spirometry, those two things in conjunction with a negative IgE result, but yet the spirometry is variable, as you've indicated. I'm just trying to make sense of what I see as perhaps two polarized sets of data.
That's because you're looking at it two different ways, I think. So don't forget, spirometry and urine is there for, well, they're all different. Spirometry is there to do surveillance of the person to see if their lung function's changed. And spirometry is actually a really poor way of identifying occupational asthma. Because as you saw, if you give people 3 days off and then do their spirometry, it's completely normal. So it won't tell you anything. The urine just tells you about the monitoring on that day. So it might be negative and that's reassuring, but on another day it might not be, and it doesn't really tell you everything. If you've got a person with symptoms at work, then neither of those things are going to help you, and nor will the blood test. The blood test could help you if it's positive, but it's negative, it's no help whatsoever, because it could be either negative because it's true negative or negative because it's false negative. So there you've got to go back to the history and then peak flows. And if that doesn't give you the answer, that's when we challenge people, which is variably challenging with isocyanate because it kind of depends on their exposures. But we do have a great protocol for isocyanate challenge, and we've done loads. It's quite a good test. So yeah.
And what does that involve then?
Well, as I showed you, a few days in hospital, and then they're exposed to short bursts of isocyanate within health safety. But it depends which isocyanate it is as well, because obviously there's HDI, MDI, TDI, and you need to get the
it's predominantly TDI, very small amount of MDI, but predominantly TDI.
Yeah, so again, these become very case by case discussions, because when you're getting to, you can't do that on everybody. You've got to, like, as I said, for me, I always start with symptoms first. So people don't have asymptomatic occupational asthma. It's not a thing. You can't have asymptomatic asthma. You can have an asymptomatic drop in lung function, but that isn't normally due to asthma. So then you've got to look into it a bit more.
Okay, thank you.
Oh, welcome. Oh, that's my admin email. Could I put the other one? How many times a day peak flow? Every 2 to 3 hours, Michelle. So it depends how long you stay awake for. If you're one of my teenagers, then it'll be quite a lot. And if it's me, fewer, because I go to bed earlier than them. But yeah, every 2 to 3 hours. You end up with 6 to 7 measurements a day, which is plenty. No problem. As I said, a lot of this is summarised on our website as well, but you've got the recording, you've got access to it, so you can listen to me again. But if you've got any specific questions about either cases or workplaces, or you want some guidance about a surveillance program, we do all of that through our advice email, which I've just put on there now. So yeah, that's what we're here for, really, to help you. But that's just what I presented as an overview of a quite random group of, assorted group of cases that we've seen that are related to people saying, has this person got occupational asthma? And of course, some of them do and some of them don't. So yeah, that's me.